Hello, everyone. I think it's time to begin this webinar, and I would like to share my screen with all of you. A minute. So welcome to everyone, and thanks for connecting to this webinar. This will be about treatment options in idiopathic inflammatory myopathies. I'm the moderator, and I'm Associate Professor Louise Dietrichsen from Department of Rheumatology, Copenhagen in Denmark, and I'm a member of the ERN Reconnect IIM disease working group. Our speaker today will be Professor Jiri Vencovsky. He is from the Institute of Rheumatology in Prague in Czech Republic. He is a member of the ERN Reconnect IIM disease working group as well. And I would just want to remind you that this webinar will be recorded and published on the ERN Reconnect website, as well as on YouTube channel. For questions during the webinar, use the question and answer session in the Zoom black bar or use the chat, and preferably the chat. Questions will be addressed to the speaker after the session. And please, Jiri.
Okay, thanks for the introduction. Now I'll try to share my screen. So can you see the full or not?
We can't see the full Jiri, but if you reduce the column at the left side as well, then it will be fine. Exactly, it's fine.
I would prefer it. I try once more. Because we achieved it before. So
Thank you for your patience. We'll just try once more.
I'm sorry, I would.
Yeah, but it's okay. We will try once more. Otherwise, it's not a problem.
I'm sorry, I can't manage. I think it's gonna be. It will have to be like this.
Yeah, but it's fine.
Is it okay?
Mm.
Okay, so welcome to the presentation on treatment options in myositis or inflammatory myopathies. I will do a short introduction, how we treat and how we assess the treatment, and then I will go directly into the ways of treatment, and I will demonstrate how we treat these patients on one case that we treated with different possible scenarios and drugs. And in the end, I will tell you something about the most recent publications that of the drugs that are used in patients with myositis. So I start with the overview, how at least we, our in the center, approach patients with myositis. As most of the others, we start with glucocorticoids, and in dermatomyositis, we usually start with the antimalarials at the same time. In many of our patients, we start also with the synthetic immunosuppressives at the same time as glucocorticoids, but in some of them, we try first glucocorticoids, and if they are not effective enough, we taper them and add the synthetic drug. If they are not effective, we still taper because they are not effective. And these drugs that we use are methotrexate, azathioprine, mycophenolate, and so on. And if these fail, we give intravenous immunoglobulins, rituximab, other biologicals, JAK inhibitors, apremilast, or we can put them on patients on clinical trials, on some experimental treatment. And I have to stress that although it's not pharmacological treatment, physical therapy is very important for all the patients with myositis. It's important to distinguish between the activity of the disease when we have a new case. Of course, this is an inflammatory activity we have to treat, but in advanced cases, sometimes it's difficult to distinguish between the muscle weakness that originates from the inflammation and that originates already from the atrophy and damaged muscles. And of course, the ways of treatment are very different in those two situations. And MRI is a very good tool to distinguish between the atrophy as it is. Can you see the pointer or not? Can you? No.
Yes, I see.
Okay, so it's here in the bottom, whereas the top and the middle is, although there is a lot of atrophy, this is still ongoing activity because there's edema. So how do we assess the effect? We used to have definition of improvements for adult patients where we assessed physician global activity, patients global activity, muscle strength, HAQ, physical function, enzymes, and extraskeletal muscle disease. And the definition is at the bottom written. I'm not going to repeat it because we have now new definitions since 2017, and it uses exactly the same core set measures. However, these are sort of graded, leveled into several levels, and these levels based on the magnitude of the response. And all these levels are assigned certain number of points of the improvement. And I have here an example of a patient who improved, let's say, from 50 to 40 on the visual analog scale in physician global activity, which is here in between 5 to 15%, and the patient received 7.5 points. These different core set measures are weighted. So the highest weight is given to manual muscle strength. So patients who improve, let's say, between 10 to 20% receive 20 points as an improvement. And it's summed up, and we come up with the result is total improvement score of the patient, which is between 0 and 100. In this case, it was 57.5, which is moderate improvement. And we can also use the absolute number. And I will be showing you some results. So I thought which are expressed in the TIS total improvement score. So I thought it would be good to remind you about this possible assessment. So I go now into the detail about the case presentation. This is a male patient, 25 years old, that presented to us probably 20 years ago, and he had severe muscle weakness. He had severe difficulties in swallowing, and he had arthritis, particularly in his knees. He had very high CK, cytoplasmic ANA. Only later we detected it was anti-SRP antibodies, and he had positive EMG biopsy, and he was diagnosed then polymyositis. Now we would call it immune-mediated necrotizing myopathy with anti-SRP antibodies. So how did we treat this patient? Because it was a very severe case, we thought at the time that pulse glucocorticoids would be a suitable approach to this patient. So we administered 3 grams of methylprednisolone and continued with glucocorticoids 1 milligram per kilo a day, which is what is recommended. We encountered some complications, not immediately, of course, but in weeks or several few months. And this patient had multiple vertebral fractures, and he also developed femoral head necrosis, which later on required total hip replacement after 3 years. So this is something which keeps repeating, I mean, in many patients. So could we use a different approach? And the answer is yes. And we use it from time to time nowadays. There are 2 publications that probably show how to decrease the side effects of high glucocorticoid treatment. This is, I think, Japanese studies 10, 12 years ago, where they compared the alternate dosing of high dose prednisolone to daily dosing. And although the final dose of the glucocorticoids was the same, those patients who received the alternate dosing did actually better in terms of side effects and had the same efficacy as those who received the prednisolone daily. And particularly after they were followed for many years, after 10 years, it was not significant, although there were more patients who survived. But after 20 years, there were many more patients who survived in those who received the alternate dosing. The other possibility is taken from the paper by Marianne de Visser and her group from Amsterdam, and they tried to treat patients with pulse dexamethasone therapy versus daily prednisone, and they compared it. Dexamethasone was given to patients for 4 consecutive days in a month, in 4 weeks. It was 40 milligrams a day, and they were treated for 6 months. And it was compared to prednisone either 70 or 90 milligrams according to the weight. And the result was the same composite score. Patients who had prednisolone achieved remission slightly more frequently than those on the dexamethasone, and also they had longer time to relapse than those on dexamethasone. But on the other hand, those who were on dexamethasone had really less side effects, such as diabetes, for instance, 4% versus 33%, and other side effects of glucocorticoid treatment. So this is something which we use from time to time, particularly if we have a very severe patient with a lot of comorbidities and diabetes and already present osteoporosis and so on. So this is one way how to reduce the possibility of severe side effects of glucocorticoids. So we treated our patient with glucocorticoids, but there was very little improvement of muscle and joint disease, and also dysphagia persisted. So we decided to add immunosuppressive agents. So there are a number of them. Probably mycophenolate or cyclophosphamide are the most effective, but we don't know about the others. This is taken from of the paper that we published several years ago, where we compared methotrexate and cyclosporine. And as you can see in these graphs, basically the effect was very similar between this with these 2 drugs, with one exception. Creatine kinase decreased more rapidly and more in those patients who were treated with methotrexate. We also conducted a trial where we compared the patients who were treated with prednisone alone and prednisone and methotrexate. The primary outcome was the total dose of glucocorticoids, because we thought when we add methotrexate, it would allow us to decrease glucocorticoids more rapidly in 1 year. However, this was not the result that we saw, and both groups did basically very similar. It was because most of them improved very rapidly and very well, so we could decrease the dose of glucocorticoids in both groups. There were also some other trials that tried methotrexate, cyclosporine, and so on, without showing an effect on the course of patients with myositis. There is one exception, but it's in children. So this is a new onset juvenile dermatomyositis and Printo study where they showed that methotrexate and cyclosporine are better than prednisone alone. And particularly it was the methotrexate that achieved, patients who on methotrexate achieved the remission more frequently than patients with a cyclosporine. So probably easier to see it in children. We all give methotrexate, but still we lack the real evidence in the clinical trial that's effective. So we treated our patients with methotrexate, combined methotrexate and cyclosporine A, but there was no effect. So what were the next possible steps? Other cytotoxic drugs like cyclophosphamide, intravenous immunoglobulins, or biologicals, or some experimental treatment. Because at that time, there was just a time when a RHIM study was initiated, and we had several patients in that study. We included this patient into the rituximab in myositis study, RHIM study, where patients received rituximab or placebo and rituximab. So it was a delayed onset of the drug here in this arm. And we treated our patient. He received 2 infusions of rituximab. He improved a little bit. His MMT8, both sides, maximum is 150. He improved from 97 to 106. This is some improvement, but not much. There was no improvement in global activity according to the physician. Creatine kinase remained stably elevated. There was no change in extramuscular involvement. We re-biopsied these patients and we saw some the inflammation slightly subsided and there was less necrosis in the biopsy. So in total, it was not really striking effect of rituximab. And this was actually seen in other patients as well, although many patients improved, but in both arms, it was the same. So there was no difference in time to response in these patients. In children, there were also juvenile patients treated with rituximab. There was some trend to have early response in those patients who received rituximab first and then placebo, but it was not significant. Patients who had anti-Jo1 antibodies, anti-Me2, showed in sub-analysis better response than other patients with other autoantibodies. So there is a probably different response to rituximab in different subtypes and subgroups of patients with myositis. So we thought what we would do next. At that time, we had another chance to put a patient into the clinical study with intravenous immunoglobulins. This is what we did. And he received 5 monthly cycles with 2 grams per kilo, which is normal dosing. But he was a non-responder. Actually, there was basically no response to intravenous immunoglobulins in this patient. I think I need to mention that intravenous immunoglobulins were a year ago approved for treatment of patients with dermatomyositis. So this is a completely different subgroup of patients with myositis, but because it's a real achievement, I want to show you the results, because this is the first drug after many years that's approved for the patients with myositis, and there's only Acthar gel in United States that's approved for the treatment. Otherwise, all the other drugs are off-label sort of, and many drugs failed in clinical trials. So this was the trial that show a difference between patients. This is the blue column, this one, who received placebo and against patients who received octagram intravenous immunoglobulins after 16 weeks. And this is the minimal response, total improvement score more than 20. But significant response was seen also in those who received this over 40 or even over 60, which is called major response. The response is fast, as you can see already in 4 weeks, there is a difference. And those patients who initiated placebo and were transferred to active drug after 16 weeks actually catched up with those who received intravenous immunoglobulins from the very beginning. There are some side effects. A lot of is discussed about the thrombosis, thrombotic effect, which were seen in 6 patients in this particular study, but this is not seen always. And there was a just very recent paper from, I think from Boston, where they looked at retrospectively into their patients who were treated with IVIGs, and they didn't see the difference between those who received IVIGs or were treated with different drugs. So apparently that's not so common, and the drug is quite safe. I just for the interest, these are individual items from the this, and this is one of our patients that we treated, and you can see she received the placebo for the first 16 weeks, and you can see the sharp improvement in the following weeks when she received the active drugs, and decrease of the cutaneous improvement and extramuscular activity, and improvement in the patient's global activity, and also some improvement in manual muscle tests. So it's sometimes it makes marvel in patients particularly with dermatomyositis. Unfortunately, it's not that effective, with the exception of immune-mediated necrotizing myopathy with HMGCR antibodies in other subgroups of patients with myositis. So what next? So we had a patient who failed even intravenous immunoglobulins. So again, we used the advantage of the trial that was just ongoing and put the patient into the trial with Abatacept. There were 2 trials. First, it was the investigators-initiated trial where we participated. There were 20 patients treated. It was the phase 2, and the trial was also, with respect of design, it was the delay onset. So there was no placebo, but some patients started with the active drug and were treated for 6 months and then followed for another 3 months. And the other arm, these were patients who were followed for 3 months and then treated with the active Abatacept and compared. So the first 3 months was actually active drug against, well, nothing, because there was no placebo. And this Artemis, there's a trial showed some promising results. At 3 months, in the arm of those patients who were treated from the beginning with Abatacept, 50% responded, whereas only 1 in the other arm, because of the low number of patients, this was not statistically significant. When the trial was reanalyzed with using the TIS, in this case, after 3 months, there was a difference that was statistically significant. So this was a good result, and therefore the phase 3 trial was organized. It hasn't been published, but the results are available. I could access them on the clinicaltrial.gov, and I think these are going to be published very soon. However, this was essentially negative trial, although there was some trend for those patients who were treated with Abatacept. Here, 56% fulfilled the definition of improvement compared to 42 plus 0.5%. This was not statistically significant, but close to. And this was better slightly than in patients with placebo. Muscle endurance was better. Extramuscular decreased more than in those patients who were on Abatacept. However, it's in the phase 3, it was a negative. This is what happens quite often when phase 2 is promising and when a large phase 3 trial is organized. So there was, in this patient, there was no improvement in the trial with Abatacept, very little. So what we did, there was not much at that time where we did it, there were no other drugs. And because we saw a little bit of improvement after with the rituximab in the RHIM trial, we reintroduced these patients to rituximab and repeated infusions every 6 months, and the disease somewhat stabilized. And what's interesting, his anti-SRP antibodies disappeared and are no longer detectable until now. And he's still treated for the last 10 years with rituximab. He's doing relatively fine. So this was 10 years ago. So what could we do? What can we do else nowadays? There were several trials published. One was with tocilizumab. Tocilizumab showed in case reports some promising results, but the phase 3 trial, you can see the results in here. The blue line is placebo, and actually it ended up with better improvement in the total improvement score in this than tocilizumab, so negative result. There was a trial with belimumab just published very recently this month, and again, there were not significant differences between belimumab and placebo, although there were also some suggestions that belimumab might be a little bit better because patients who achieved definition of improvement at week 40, there were 33 versus 17%, more than 40, 56 versus 33%, it's almost double. Major TIS, which means major improvement, 22% with belimumab, 0 with placebo. However, mean TIS, you can see the curves, which is belimumab, and this is placebo, and they are actually overlapping. So again, basically failure. So then we have JAK inhibitors. There were many case reports and small case series, so I selected only few. There is a one trial, open label, with 10 patients. All of these 10 patients with dermatomyositis improved and actually achieved mean TIS 40, which is quite high. And when these patients were treated this was for the 12 weeks, and when they were treated in open label, in the extension study, they maintained the efficacy. And particularly, it was the skin disease that improved, and less muscle disease. So this is another study from China where they compared the patients with interstitial lung disease, and they found historical controls, and they compared them to patients who were treated with tofacitinib, and they found better survival of those patients on tofa. And final slide from these are patients who have very bad prognosis to the future because they have hypo or myopathic dermatomyositis with MDA5 antibodies, and they have this rapidly progressive interstitial lung disease. And if they have high ferritin and a lot of ground glass opacities and do not respond to treatment, most of them, actually all of them, died by 2 months. When they were treated with tofacitinib, it was 50% survived, 50% of them died. Tofa was also tried in treatment of calcinosis. We all know that it's very difficult to treat calcinosis, And there are some suggestions, although very few patients were treated. There are some suggestions that it may be effective in patients with calcinosis and may lead even to disappearance or reduction of the calcium deposits. And last two case reports, there was a case report, two case reports actually, with daratumumab, which is anti-CD38 monoclonal antibody. CD38 is found on plasma cells, and quite a significant effect was observed in this monoclonal antibody. One of them was anti-SRP positive necrotizing myopathy, and in this patient who failed basically everything, IVIG, rituximab, plasmapheresis, had to be put on mechanical ventilation because of the weakness, and had to be fed by parenteral nutrition and so on. When he received daratumumab, he started to improve, and actually he walked away from the hospital, reduced the CK, and what's interesting, as in our patient, anti-SRP antibodies in the end disappeared. And final slide, or the one before the final, is the CAR T cells treatment, and you probably all are aware of the case report that was published in Lancet this year, and a patient with antisynthetase syndrome that was very severe and refractory responded to the CD19 targeted CAR T cells. And you can see the level of the creatine kinase here. He failed rituximab and IVIG, tacrolimus, rituximab, cyclophosphamide, and improved very rapidly with administration of CAR T cells, and improved his myositis, lung disease, and you can see effect on manual muscle test and the patient's global assessment. Anti-Jo1 antibodies disappeared, and actually this was above 80 after already 30 days. Final slide just shows what will be the future, or what might be the future. So these are some selected ongoing studies or studies in preparation that we either participate or could be found on clinicaltrials.gov or other repositories. So particularly JAK inhibitors such as baricitinib, brepocitinib, which is JAK1 TYK2 inhibitor, or this is from Galapagos, TYK2 inhibitor are being tried. There are two drugs that target to the same target, which is FcN receptor on the cells, which binds immunoglobulin G and helps to recirculate. And if you stop this pathway, IgG does not survive and leads to the decrease of IgG, including of autoantibodies. And it was shown to be effective, particularly in myasthenia gravis, for instance. Ravulizumab in dermatomyositis, it's an antibody against a complement. We all know about the complement in dermatomyositis. Daxdilimab kills plasmacytoid dendritic cells, but then there are some others. Interesting is glucagon-like peptide 1 receptor agonist, that these drugs are used in diabetes and also for to reduce weight, but they have some anti-inflammatory effect as well. So we will see whether there will be an effect in myositis. And there are some others, including antibodies against interferon receptor, and also study with CAR T cells. So with that, I will finish, and I will be happy to take questions. Thank you very much.
Okay, and thank you to Professor Jiri Vencovsky. And I will now get into the questions. Jiri, we have a question. Is there still inflammation in the muscles when the myositis is in remission?
Say that again, sorry.
Is there still inflammation in the muscles when the myositis is in remission?
Yeah, that's difficult to say. There might be some inflammation, but we at one point we biopsied our patients before and after the treatment, and sometimes we even biopsied them from the part that was affected on MRI and that was not affected on MRI. But and we saw still some inflammation in those patients who were treated, and all in those muscles that looked unaffected on MRI. So in some patients, yes, there might be ongoing inflammation, but in many patients, it totally disappeared. So after 3 months, when we biopsied them, the inflammation is gone. So it's from patient to patient, so it's individual.
Yes.
The question is probably goes to the fact whether we should treat these patients despite they may have some remaining in the muscle. But I would not treat with aggressive immunosuppressive treatment those patients who do not show signs of inflammation, for instance, on MRI. I would probably use more physical treatment for these patients.
Yes, and the questions here, considering the possibility of cancer associated to IIM, also in 2 to 3 years after the onset, would you be keen to prescribe JAK inhibitors in IIM patients also in the time interval? Did you get
That's something that has come in the clinic to me already, and I discussed it in with the patient, and I outlined the possible benefit from JAK inhibitor, and of course the possibility that it may lead to the relapse of the cancer. And with the patient that was just recent, he opted to be treated. So we treat with him with JAK inhibitors. But I think it's individual. We need to discuss. Yeah.
And did you see any results yet? How long time was that before?
Well, with this particular patient, it's about a month ago. So, but I saw good results in some other patients. Well, without tumor, of course. But yeah, not all patients respond to JAK inhibitors, but it's a good drug. Yeah.
Yes. I don't see any more questions. Yeah, that's another one. In case of myositis from statins, how to treat pharmacologically?
Yeah. It's actually, if you mean immune-mediated necrotizing myopathy induced by statin, usually with anti-HMGCR antibodies. Well, we see these patients quite frequently nowadays, and we start with glucocorticoids and give synthetic immunosuppressive drug first, which means usually methotrexate. And many patients respond to this. If they do not respond, we try some other immunosuppressive drug. And if they don't respond, we usually go to intravenous immunoglobulins because these patients have a very good response to IVIGs in contrast to anti-SRP necrotizing myopathy. So not all of them respond. Again, I have some non-responders or some patients who responded initially, but then lost the response to IVIGs. But this is something which accepted that the best drug for these patients, if they are resistant to other treatment, are IVIGs, and it's preferred to rituximab because the effect is bigger.
And can I comment on that theory? Have you got limitations regarding IVIG, or would you be able to use it upfront as first-line therapy for these patients with immune-mediated necrotizing myopathy?
Well, if I understand the question, it's about whether we would be able to use it earlier or up from the beginning.
Mm.
Yeah, well, it's not possible in this country. You know, we have to prove that this patient is not responsive to the usual treatment that we give. But it would mean, you know, most of the patients respond to immunosuppressive treatment. So it's not like that all of them require intravenous immunoglobulins. It's 1 of 10 or something like this. All the others usually respond to immunosuppressive treatment. Yeah.
Yeah, I can't see more questions right now. Let's just wait a few seconds, see if anything is coming up. I don't see any more questions. So I would like to thank everyone, including our speaker, Professor Jiri Vencovsky, for this very interesting webinar, and the rest of all of you participating, and the Reconnect organization as well for organizing this webinar.
Okay, thank you very much for having me.